welcome her to talk about the histologic spectrum of triple-negative breast cancer. And we know that that group is quite heterogeneous, so we're very keen to listen to Dr. Sahin. Thank you.
Can you open it for me?
Yeah, it's open, but it just takes a minute.
Just open. Then put it in there. Okay, so we're going to continue with this spectrum of triple-negative breast carcinoma, and I would like to thank our panel for summarizing it for me. It is a wide spectrum. So that is going to be the take-home message, actually. But let's go and see what we have. So the terminology of triple-negative breast carcinoma was introduced in early 2000 to describe the subset of breast carcinomas. And then the typical feature is it lacks the ER, PR, and HER2. And I would like to stress one thing, that when we are calling something negative, we really have to make sure that, one, our stains has worked. Number two, we have an internal control. So it's really important to make sure that we have internal control. So calling something positive is always easy, but calling something negative, we really have to make sure that we don't have any technical issue. And in around 2000, we also have the microRNA data, and based on that, we have the basal-like carcinoma based on the gene expression profile. Even though these two entities were mixed and many clinicians use it interchangeably, we know that they do not overlap 100%. And today, most likely triple-negative breast carcinoma is used as an umbrella term. And it includes all these different entities with genetic, transcriptional, histological, and clinical features. And probably within 5 years, 10 years, we are not going to use this term anymore, because now more and more we are identifying the special subtypes of these tumors. So today, briefly, I would like to go over this different histologic and molecular subtypes of triple-negative carcinoma, characteristics of pathogenesis of each subtypes, and recent advances in our clinical practice. Diversity is going to be the word for triple-negative carcinoma. So we have the histologic diversity. In terms of clinical presentation, these tumors tend to have more circumscribed compared to invasive ductal carcinomas, otherwise specialized. So it doesn't have to be, but typically they are. And that the circumscription can also be appreciated histologically. And these tumors usually have solid growth pattern with dense lymphoplasmacytic infiltrate. And they are also associated with spindle cell elements. And importantly, these are high-grade tumors with increased mitosis. And if you have these lesions on small corneal biopsies, and when you have a high-grade spindle cells, this is our differential diagnosis. It can be spindle cell carcinoma, sarcomatous overgrowth of malignant fluidous tumors, or primary sarcoma. And there is no way on a core biopsy you're going to say, this is this, this is that. It is very difficult because the morphology and immunohistochemical profile are going to overlap. Many of the high-grade spindle cell carcinomas, their keratin expression can be low, and some of the sarcomas can also have low expression of keratin. So markers will also overlap. And the best bet is if we can see areas of epithelial clusters like this. I don't see the arrow here. So if you can identify the epithelial elements that is on the corner of this slide, then it's a good clue. Obviously, if you can see in situ carcinoma component, it's also a good clue that that's a sarcoma. It's a carcinoma, not sarcoma. And immunohistochemical staining P63 can be positive, but it is very important to recognize that the phylloidous tumors can also be P63 positive. So it's markers are important, but we really need to know the pitfalls of each marker. Metaplastic carcinomas have been already discussed, so I'm going to go real fast on these. Matrix producing carcinoma is part of the triple negative breast carcinoma. It can be either osteosarcoma or chondrosarcoma. And our previous speaker also described this adenosquamous carcinoma. If you see well-formed glands and you do your markers and it is ERPR negative, think about adenosquamous carcinoma. These are triple negative, but these are low-grade tumors. Fibromatosis like metaplastic carcinoma, again, it's a low-grade aspect, but it is triple negative breast carcinoma, and having the immunohistochemistry for cytokeratin is important, these things. And the most important category, and then we have more advances in the classification of tumor, is this in the salivary gland-like tumors. Acinic cell carcinoma, adenocystic secretory carcinoma. Now we have special methods to identify these tumors, and the more we study them and their salivary gland counterparts are very morphologically and molecularly very similar to breast carcinoma. One of the specific diagnoses we should be really making is secretory carcinoma. Earlier today, we talked about all these rare types of tumors like glycogen-rich, lipid-rich, and secretory carcinoma mimicking each other morphologically. I agree with the lipid-rich and glycogen-rich. They really do not have any prognostic and therapeutic implications, but secretory carcinoma is exception to that. Because these lesions have excellent prognosis, and more importantly, they have specific immunohistochemical profile, and we have specific genetic abnormality, and more importantly, we have a targeted therapy for this tumor. It can have solid or microcystic or tubular architecture. They are GATA3 positive, more importantly, SOX10 positive, S100 positive. That S100 positivity is important, but many other invasive ductal carcinomas can also be S100 positive. So never do single marker alone. We always do the panel of markers. When this is that there should be one more slide here, but I cannot bring it. So the characteristics of secretory carcinoma is the translocation of chromosomes 12 and 17, forming this fusion gene, which we have a specific FISH probe for that. And identification, this one is extremely important because especially in metastatic setting, these not only the diagnostic marker, but also it is, I am skipping some slides. Is there anyone who you can help me on that? So there needs to be another slide here. So we have a NTRK inhibitors that we use in clinical practice. And there should be a graph here showing that patients who receive NTRK inhibitors in a metastatic setting, their response rate is very high and they have a good outcome. So it is important to identify secretory carcinoma. And the second salivary gland type breast carcinoma that we need to recognize based on morphology is the adenoid cystic carcinoma. And adenoid cystic carcinoma in the breast has the same morphology as adenoid cystic carcinoma anywhere else, especially in salivary glands. It can have solid cribriform and cystic areas. And morphologically, when we see these tumors, one, we need to make sure that this is not a metastatic carcinoma. Number two, the grading in these tumors in breast carcinoma doesn't seem to have any significant prognostic implication. And just like anywhere else, these adenoid cystic carcinomas in breast, they are CD117 positive, and they also are positive for P63. And even with low-grade tumors, they are ER/PR and HER2 negative. So they are part of the triple-negative breast carcinoma. And just like salivary gland adenoid cystic carcinomas, this MIB-NFIB fusion is the diagnostic for adenoid cystic carcinoma. And most of the time, the pathway is activated by this fusion gene, but alternative genetic mechanisms such as rearrangements of MIB-L1 is also being shown to be important. So not only this fusion gene rearrangements, also the MIB amplification has been identified in these tumors. So overall, they are MIB pathway-driven tumors. And this MIB protein can be identified by immunohistochemistry. So we frequently use that when we have it on H&E that we are suspecting adenoid cystic carcinoma. These salivary gland type basaloid carcinomas, in terms of their classification, can be sometimes problematic, especially in core-needle biopsies. It is really important to understand that having the MIB protein positive immunohistochemistry is not specific for adenoid cystic carcinoma. Cutaneous adnexal tumors should be also in the differential diagnosis, and they can be MIB protein positive. And we have had cases coming as a chest wall mass / breast mass, and it turned out to be, it was a cylindroma. So it is really, when we have small biopsies, we have to make sure that the lesion is in the breast, and we cannot make the diagnosis only one based on MIB protein expression. If it's an adenoid cystic carcinoma, regardless of the grade, these are very favorable prognosis tumors. The overall survival rates on these is really very high. And these are rare tumors, but it's really important to recognize them. It has been reported that solid variants characterized by these infiltrative solid nests and geographic rounded islands with high mitotic rate, their prognosis is not as great as classic adenoid cystic carcinoma. And again, these are rare tumors, but if it is predominantly solid, they do better than invasive ductal carcinoma, but they are not as good as classic type. And when we look at the solid variant of adenoid cystic carcinoma, in addition to having the MIP pathway abnormalities, they have additional mutations. And most commonly, these additional mutations involve in the Notch pathway or CRAB-B mutation. So it is really important to do the molecular analysis of these tumors. And other rare salivary gland type tumors such as mucoepidermoid carcinoma, polymorphous adenocarcinoma, they all have shown to have the same mutational analyses as their salivary gland counterparts. So identification of these specific molecular abnormalities is important. Another triple negative breast carcinoma is the tall cell carcinoma with reverse polarity, which is a rare lesion, but most importantly, these tumors are driven by combination of IDH2 hotspot mutations or ET2 loss function or mutations. Mutations affecting PI3K pathway have also been reported, but in our clinical practice, we use the IDH2 immunohistochemistry. And when we look at the 3D models of non-malignant breast epithelial cells, when you have this IDH2 abnormality, it becomes, they acquire the reverse polarization of the epithelium, which is the hallmark of this tumor. And again, it can be demonstrated by immunohistochemistry. Actinic cell carcinoma of the breast is a low-grade tumor. Again, if you have a lesion which appears to be low-grade, but when you do the ERPR, it's negative. And if it has these eosinophilic granules, think of actinic cell carcinoma. Very rare tumors, we usually have 1 or 2 cases at most in a year in MD Anderson, and they harbor P53 and PI3 kinase mutations. And most importantly, that they share molecular abnormalities with breast carcinomas arising in the background of microglandular adenosis. So the studies looking at the comparative genetic abnormalities of actinic cell carcinoma and microglandular adenosis, they showed, as you can see, very similar molecular changes. So these studies suggest that maybe microglandular adenosis is the precursor lesion of high-grade triple-negative breast carcinoma, especially actinic cell carcinoma. So from the morphology point of view, we have this wide spectrum, and accurate histologic subtyping is essential for appropriate clinical management. High-grade and low-grade forms are fundamentally different, and their, most importantly, response to therapy are quite different. In terms of their molecular diversity and pathogenesis, as I mentioned before, with the initial studies of gene expression profiling of breast carcinoma. The triple-negative breast carcinomas were classified under the basal-like breast carcinomas. And many comparative studies have shown that although there is the 70 to 80% of overlap between basal cell, basal-like carcinoma and triple-negative breast carcinoma, when you look at the triple-negative breast carcinoma, the other types such as luminal A, luminal B, normal-like can be identified in that category. Similarly, when you look at the basal-like carcinomas, although great majority of them are triple negative, there are some hormone receptor positive or HER2 positive tumors. And subsequent studies have subclassified the triple negative or basal-like carcinomas into different categories as basal-like 1, 2, immunomodulatory, mesenchymal-like, mesenchymal stem-like, and luminal androgen receptors. And each category, when you look at the individual studies, they have specific expression patterns of specific markers, such as Claudin 3, 4, and 7 is a very specific marker for Claudin low category. Similarly, molecular androgen receptor positive tumors also had specific morphologic features, and 10 to 15% of triple negative breast carcinomas are under the immune modulator type molecular subtyping, and these are morphologically what we used to call as medullary or medullary-like breast carcinomas, and majority of these patients had BRCA1 carriers. And the molecular androgen receptor positive tumors are enriched in hormonally regulated pathways, and these tumors also show apocrine morphology and high expression of luminal cytokeratins. And are any of these specific markers used in classification in our daily practice? And the answer is no, except for androgen receptor. If we have a tumor which has more morphology for apocrine carcinoma, and if it is ER/PR HER2 negative, we perform androgen receptor because many patients respond to androgen receptor targeted therapies. Other than that, the identification of immunosuppressed or immune activated subtypes, even though there are specific markers identified in studies, in clinical practice we don't use these. When we look at the germline mutations among patients with triple negative carcinoma, again, we see extensive diversity. When we look at the BRCA1 mutations, most commonly in triple negative breast carcinoma, but BRCA, like homologous recombination DNA deficient phenotype, also defined as BRCA-ness of the tumor without the absence of BRCA1 or 2 mutations. In the past, when we looked at the germline mutations, we used to look at only BRCA, BRCA1 and 2, but now we have different panel of markers. So we are performing multi-gene panels for identification of germline mutations. One of the newcomers in that is the PALB2 mutation carriers, and these patients have really increased risk of developing breast carcinoma. So now in the clinical practice, as opposed to looking at 2 genes, we are performing multi-gene panels. And the importance of identification of these, especially the BRCA1 loss function, is that these patients have exquisite sensitivity for PARP inhibitors. So this really is becoming important. And in our clinical practice, any patient who is diagnosed with triple-negative breast carcinoma, patient is referred to genetic counseling. And based on other clinical and familial features, these patients are sent to gene panel evaluations. But all patients with triple-negative carcinoma now is evaluated. In the past, it used to be only patients, premenopausal patients, but now all patients with triple-negative breast carcinoma. And in terms of tumor immune microenvironment, again, we have a wide distribution. We know that tumor microenvironment is also a very dynamic concept, including not only the cytotoxic T lymphocytes, but macrophages and cytotoxic granules and macrophages. And it has been shown that prognostic value of TILs is more important in triple-negative breast carcinoma and HER2-positive breast carcinoma. So when we look at all tumors, there is some prognostic significance, but especially when we look at the triple-negative breast carcinoma, TILs are prognostic. So based on this, there are some recommendations that whenever we make the diagnosis of triple-negative breast carcinoma, we should give the TIL score, but still in United States, giving TIL score is not part of the ASCO-CAP guideline. One of the major issues is evaluation of TILs and the scoring systems. There are still a lot of controversies. But when you look at large studies and then when this is evaluated by a specific group of pathologists, it has been shown to be very prognostic, and every 10% increment of TILs, it's associated with at least 13% of relative risk reduction in survival. So it is really important. Again, this should have more slides, but it didn't make it. So we are not using the medullary carcinoma terminology anymore, but a majority of these triple-negative breast carcinomas are associated with these circumscribed growth and a large number of TILs. And whenever whether drug-specific immunomodulation properties or engaging different immune effector mechanisms are associated with different clinical outcomes is still unknown, and it's a very intense area of research. And another very important part of TILs is that especially after neoadjuvant therapy in the residual disease, if we have residual disease, presence of high TILs is also prognostic, and some studies require that we should report these. I'll pass these. And then other biomarkers in triple-negative breast carcinoma, as I mentioned before, GATA3 is a very limited utility identification of triple-negative breast carcinoma. And some studies suggest that SOX10 is an important marker to identify triple-negative breast carcinoma, which is true, but it is not specific for breast carcinoma. We have to remember that it can stain other things. And as I indicated before, TRPS1 now is extensively used in our clinical practice. One thing that I did not mention in my previous talk is that we have to be careful with TRPS1, which is the apocrine carcinoma and neuroendocrine tumor of the breast. These tumors can be negative for TRPS1. So if you have an apocrine morphology, and if it is TRPS1 negative, don't exclude breast primary. So androgen receptor, we've used it as a therapeutic target in triple-negative breast carcinoma. In terms of clinically meaningful approach to classification of triple-negative breast carcinoma, we have to identify the special types with better prognosis, such as the salivary gland-like tumors and secretory carcinomas. And then the other important thing is that we really have to identify truly non-endocrine responsive tumors. We see a lot of patients who are referred to our center as ERPR HER2 negative, but when we repeat the ERPR staining, they are 10%, 20% positive. Especially now with the definition of low HER2 and then specific treatment for low HER2, this basket of triple-negative breast carcinoma is probably going to be shrinking down a little. So we really have to add relevant biomarkers based on morphology and based on other features such as apocrine morphology and having a special genetic abnormality. So in terms of future directions, probably triple-negative breast carcinoma is either no longer used or is referred to much smaller population of breast carcinoma, and biological subgrouping will be essential for the personalization of the therapy of patients. Thank you very much for your attention.
Thank you very much, Dr.
Okay, thank you.
I believe you can stay with us for a while for questions, please. Yes, we have. Any questions, please? في مايكات للناس معنا؟ كنا باس المايك بس في قدام بعد اذنكم. دكتورة شادية.
Thank you very much.
Thank you, I appreciate it.
Dr. Aysegul. I want, as regards the lecture of fibroepithelial lesions, I want to ask about the exact nature of complex fibroadenoma. Is it considered as an entity of B3 breast lesions? And why it is considered potentially malignant, although in definition it is a type of adenoma which contain sclerosing adenosis, cystic changes, apocrine papillary metaplasia. So all the component of this type of adenoma has no relation to malignancy. Why it is potentially malignant?
Hi, thank you very much for your question. Complex fibroadenoma is not considered to be a malignant lesion. As you so rightly define, it is a fibroadenoma with any of those changes: sclerosing adenosis, cysts, epithelial hyperplasia, calcification. Some studies have shown that in follow-up studies, there's a slightly increased risk of malignancy. But I mean, we also see that with epithelial hyperplasia and even with sclerosing adenosis. So at the present time, it's fully regarded as a benign lesion. It gets a B2 categorization on core biopsy, and no further intervention is required. It is really just those follow-up studies that maybe has caused the confusion. But unless you see something like atypical lobular hyperplasia or atypical ductal hyperplasia, there's no need to excise. So it's a benign lesion, and it gets a B2 and no excision. Okay, thank you.
Can I add something for the same question, please? For the complex fibroadenoma, we don't acknowledge this terminology that much. So we don't call the complex that much. This complex introduced maybe like in the 70s or 80s by Dr. David Page. And I have the privilege to work with him at the Vanderbilt University. Then nobody used it. No, maybe in Europe for sure. Okay, but not necessarily, because this is just like benign fibroadenoma with some complexity, some complex sclerosing adenosis. Is that right?
Same thing, but usually we give a little more descriptive, like fibroadenoma with focal epithelial hyperplasia. So that is complex fibroadenoma, but we don't, I personally don't sign the cases as complex fibroadenoma. Yes.
cystic component and they
Correct.
are doubting something
Correct.
else. So if we say that it's a complex fibroadenoma, they become
Correct.
sure. Okay, thank you. I have another question, please. I want to know the difference between metaplastic carcinoma with heterologous element and matrix-producing metaplastic carcinoma, and is it important to differentiate between both, or they are?
Did you understand the question? Right.
So the question is the difference between the metaplastic carcinoma with the matrix producing metaplastic carcinoma or the metaplastic carcinoma with heterologous elements. The same. It is the same.
But I read something about
this different name.
Cells in the interface between both.
No, there is nothing. It is just a different name for the same thing. Okay. Maybe in Europe it's different. But it is, some people called it with mesenchymal metaplastic carcinoma with heterologous elements. Some others who said with matrix producing. Maybe because of matrix producing, they mean for the just cartilaginous or osseous only. Okay. Maybe. But it is the same. It is the same. So use whatever you like.
Okay, thank you. Another question, please. Sometimes we see a lesion composed mainly of DCIS, and just some of these DCIS that seem that ruptured and formed like mucinous carcinoma in the stroma. And
very good, excellent. The question is that when you see DCIS with like mucin coming out, are you going to call this mucinous carcinoma or a DCIS with mucinous features, if you will? So it is, first of all, it should be like, to call it invasive, you should have real invasion. You can use myoepithelial markers. If the DCIS is ruptured and have some cells out, still you will find bits of B63 and some myoepithelial markers around. So still DCIS. So opening and rupture with some mucin extravasation is not equivalent to invasive carcinoma.
So we don't perform the biomarkers on this and report them, or?
No, if it is DCIS, it is still DCIS. It is still DCIS. So this rupture by itself is not a feature of invasion.
I agree, but it's a difficult issue on a daily practice, especially patients undergoing multiple biopsies, all these biopsy track changes versus is it an invasive mucinous carcinoma? I don't think there is a specific histologic clue that I can tell you, but I struggle with that a lot. It is not an easy thing. There are, most of the time, I personally prefer to be more conservative than being, saying, oh, it's the mucinous carcinoma, but it is a difficult differential diagnosis.
Yeah. So you do myoepithelial markers and you watch. Sometimes it is very difficult. What I do, I call DCIS with suspicious for microinvasion, something like that. Well, as soon as you call suspicious at our institution, the clinicians, they just do the sentinel lymph node. by the word suspicion. And if it is high-grade ductal carcinoma in situ originally, so nobody care, because high-grade ductal carcinoma in situ, at least in my institution, they will do the sentinel lymph node. So you call it micro-invasion or not micro-invasion, maybe not different.
Absolutely. I agree. I think it's very difficult, and certainly I think where it becomes really difficult is in patients who've got extensive HER2 positive DCIS, where a few foci of microinvasion, while they may not qualify for chemotherapy at this point in time, I think we've all seen examples of those kind of cases that recur years later with liver metastases or brain metastases. Now, our medical oncologists will tend to offer anti-HER2-based chemotherapy to patients who have multiple foci of microinvasion if the disease is HER2 positive. I think myoepithelial cell markers are very useful, but I think it's a very tricky area, and you have to evaluate it maybe by doing deeper levels, etc., that can help to clarify the situation.
Regarding the mucinous carcinoma, I just have one question about your experience in neuroendocrine markers in mucinous carcinoma.
It can be positive, but
Yeah, very good question. Because of the time, I didn't put this. Usually, it is positive. Yes, usually it is positive. Not when I say usually, maybe 50%. It is like 50%. The behavior.
If I get in my slide, neuroendocrine differentiation in mucinous carcinoma, what is the message which I send to the clinician? It is a poor prognosis. It is a better prognosis.
So the.
Cancer, for example, if it is combined with neuroendocrine, it is a bad prognosis.
The neuroendocrine, when you say bad, you think about the small cell carcinoma. This is different. So when this is neuroendocrine differentiation, it is not the small cell carcinoma, high grade, bad prognosis. Those usually like low gradish, like the old terminology, carcinoid, if you will. And the most prognostic factor is the grade, tumor grade, and more than the grade is the stage. Okay, so it is grade. What is the Nottingham grade at the end? Then you call it with some mucinous differentiation. And by the way, doing the neuroendocrine markers on those, some good fraction of the tumors will be positive. So to start with, don't do stains you don't want to confront with strange results. Don't do neuroendocrine markers. It is mucinous, so it is mucinous. Because the more you do, the more you face some results you don't expect. Then you say, what I'm going to say. Some regular breast cancer, just regular nothing, no mucinous, nothing, like NST. Then you do neuroendocrine markers, all of them strongly positive. So are you going to call this neuroendocrine carcinoma? No. So this is, so the neuroendocrine differentiation, to answer your question, by itself, it has no prognostic value.
Why you mentioned it in our...
Because we are a pathologist and we are complex people. We are a complicated people, we are not simple. We're trying to make the simple thing difficult. Maybe showing our importance, maybe something like that. I don't know, but we try to. We have somebody say, "Why you call leiomyoma in the uterus?" Am I going to do something else? Because I have to call it leiomyoma. They do nothing after that, but I have to call it like fibroadenoma. What they are going to do next? Nothing. But am I going to leave it blank? No, we call something.
Is classified in type A and type B mucinous carcinoma.
Yes.
And the prognosis of mucinous type 1 is better than
Yeah.
type 2.
This is one of the complex people also. So this is, I just call it mucinous carcinoma, then I do the grade.
My comment to Dr. Sahin about we have to remember the history of breast cancer in examining other organs like the thyroid, for example, as a site of primary metastatic to the thyroid. Because we get one case and there was a struggle between the surgeons. They said, no, we can't from the breast and so on. Because the history was somewhat long time. Second question, how can we solve the dilemma of primary breast cancer from adnexal tumor? Sometimes you get triple negative, no, mammography is not conclusive, and you stuck with this. How can you solve this problem? Thank you.
it's a difficult, and then there are cases we cannot solve, and then we kind of give a descriptive diagnosis. So the most important thing is to appreciate the location of the lesion. So if it is really superficial, it's not really in the parenchyma, then we say it's more like the adnexal. but there isn't a definitive marker or morphologic feature that I can tell you that you can be 100% one way or the other.
Okay, can we just come to the last question, and that's from me?
Yeah,
Dr.
she had
Quinn?
a question here.
Who?
You had a...
Dr. Quinn,
Oh, okay.
can I ask you a question, please? Yeah. You mentioned the phyllodes tumors, and they very frequently undergo degenerative changes.
Yes.
And that will be a problem because that might be mixed up with some kind of a dysplasia, like the symplastic changes of leiomyoma, for example, but then you have not to upgrade it to a borderline or a malignant.
Yes, I guess that's a bit tricky when that happens. I mean, sometimes you can get a bit of degenerative change even after a core biopsy. But I think, you can differentiate that from necrosis where you'd look for nuclear debris, etc. In my experience, it's not something I see very often. And true degenerative change in excision specimens. But I think if you did see it, yes, I mean, it might be wiser to go for a borderline designation and to ensure that the lesion has been completely excised. But I think you've got to assess all of the features, take all of the features into consideration.
Well, I've been given order from Dr. Mener that is enough, and I think we come to the end of this session. We thank all the speakers and the chairpersons, my colleagues, and the audience for a very exciting and very interesting session and talks, and we hope to see you soon again. تفضلي يا دكتورة منال.
Let's take a 5 minutes break and take a group photo here, and then we'll proceed to the next session, please.